Okey. Dr. Nazrul, maksudnya soalan doktor tu patient tu dah dalam shock kalau jadi shock.
No, ada deko lagi sikit. Macam ni, my question is, patient datang inferior MI. Hypotensive episode. Then heart rate about 40-50. So you know straight away what's the culprit.
Right coronary artery.
Why?
Sebab dia punya ST elevation dia dekat lead 2 3 AVF.
So actually dia is back to basic lah. What's right coronary artery supply? So actually dia supply mostly right ventricular and as well SA node.
SA node.
That's why vital sign also important. If you tak sure is inferior MI or not, then suddenly you noted BP hypertensive ready, then dia akan support your punya diagnosis lah. Okay?
Okay.
Proceed.
So this figure show the 12-lead ECG with different anatomic location and supplying coronary artery lah. Kalau kita tengok dekat lead 1, AVL, V5 dengan V6, the blue box, it is supplied by left circumflex artery lah, lateral lead supplied by left circumflex artery. So lead 2, 3 and ABF, the red box, inferior lead supplied by right coronary artery. Lead V1 to V2 septal supplied by left anterior descending artery, and lead V1, V2, V3 to V4, anterior lead supplied by left anterior descending artery. So this first ECG show to us that there's a ST elevation over lead V2, V3, V4 and also over lead 1 and also AVL. So dia ada juga reciprocal dekat lead 3 lah minimum. So this ECG is anteroseptal MI lah. Okay, next ECG, there's ST, yang ni dia ada ST elevation dekat lead V1, V2, V3, V4 up to till V6 dengan ada juga ST elevation dekat lead 1 dengan AVL. Lepas tu dia ada reciprocal juga changes dekat lead, ada sikit dekat lead 3 dengan AVF, ada sikit. Ni kita panggil ECG ni kita kata ada extensive anterior MI. Okay, next one, third ECG. Yang ni dia ada ST elevation dekat lead V2, V3, V4, V5 dengan V6. Lepas tu ada ST elevation dekat lead 1 dengan AVL. Dengan AVL. Lepas tu ada reciprocal changes dekat lead 3 dengan AVF. Yang ni extensive anterolateral ST MI lah. Yang ni ECG ni dia ada ST elevation, memang obvious kita nampak dekat lead 2, 3 AVF lah. So ini inferior MI. Next ECG dia ada ST elevation dekat lead 2, 3 dengan AVF. Kita boleh nampak kat 2, 3 AVF. Lepas tu ada ST elevation dekat lead V1. Kalau kita nampak ST elevation kat lead V1 tu dia macam suggest macam ada right ventricular infarction. Lepas tu yang lagi buat dia ada right ventricular infarction, ST elevation dekat lead 3 ni kita nampak dia lagi tinggi daripada lead V2. Lagi banyak, lagi prominent dekat lead V3 level lead V2. So yang ni kita kata ada inferior MI with right ventricular infarction lah. Okay, kalau patient tu ada right ventricular infarction, dia preload sensitif lah. So dia kan develop severe hypotension kalau kita bagi nitrate. So kita kan kalau patient ni kita kena treat dengan fluid dulu. Okay, fluid loading. Okay, next ECG, dia ada ST depression dengan upright T wave dekat lead V2 dengan V3. Lepas tu dia ada acute T wave dekat lead 2, 3 dengan AVF. 2 dengan AVF nampak prominent lah. So dia suggest early inferior infarction. Lepas tu dengan ST depression dengan upright T wave dekat V2 to V3 ni macam dia nak suggest kat kita ada posterior MI lah. Lepas tu kita repeat ECG dekat patient yang sama. Later kita boleh nampak ada ST elevation dekat lead V6. Lepas tu 2-3 AVF pun dah nampak ada ST elevation dah. Tapi lagi obvious dekat lead 2 dengan 2 dengan AVF. So yang ni kita panggil dia inferior posterior MI, doktor. ECG ni inferior posterior MI. So next investigation that we can do is cardiac biomarker. Cardiac biomarker lah. We can send TROP-I and TROP-T are the recommended one, which because it is highly specific and sensitive. So CK and CKMB also can indicator, but it is less sensitive and specific as compared to troponin. Myoglobin is not cardiac specific, only can be detected as early as 2 hours. So kalau kita hantar CKMB, dia punya first detection is within 2 to 3 hours, and it can detect up to shorter duration lah, 1 to 2 days. Troponin I, we can detect 3 to 4 hours within patient first presentation, and it can be detected in blood within 7 to 10 days. Kalau TROP-T sama juga, 3 to 4 hour dia punya first detection, tapi dia punya duration of detection tu lagi lama sikit lah, up to 7 to 14 days. CK first detection dia within 4 to 6 hours, duration of detection dia shorter lah, 2 to 3 days. Myoglobulin lagi cepat, first detection dia 1.5 to 2 hours, and we can detect up to 8 to 12 hours lah in blood. So moving on to the management of MI approach in AD. First, we need to triage the patient accordingly, usually in red zone. And then we resuscitate and stabilize the patient first, according to the ABCDE lah. Assess the patient airway, make sure the airway is patent, breathing. Okay, take all the vital signs. If the oxygen is less than 95%, if oxygen supplementation, and assess the circulation lah. Does the patient in cardiogenic shock? Is the BP is low, and then usually if patient with MI, we set 2 large IV branula and decide lah does the patient need bolus, fluid bolus or not. And next, we establish the diagnosis lah. Take focus history, rule out other differential diagnosis. Okay, and then do a focused physical examination and do all initial investigation lah. Of course, patient presenting with chest pain, we need first of all do the ECG and then sign all the baseline blood investigation, especially cardiac biomarker, and the investigation lah, chest X-ray, and can do baseline echo if it is necessary lah. And then for the treatment, specific okay, specific to the MI, we give dual antiplatelet treatment like aspirin and clopidogrel, pain relief, and aim for reperfusion strategy lah, either PCI or fibrinolytic agent with anticoagulant lah. Supportive treatment, we give hydration, okay, IO charting, and maintain the blood sugar, and treat the complication if patient have complication lah. So we need to treat, kalau patient ada QI failure, treat accordingly lah. And then dispose the patient to appropriate places. Usually patient with MI, they will end up admit to CCU. Okay, so Kalau pre-hospital lagi, kalau kita macam suspect patient to MI, usually we give sublingual GTN, aspirin and clopidogrel. Aspirin 300 mg crush, clopidogrel 300 mg stat lah. Kalau patient more than 75 years old, we only give clopidogrel on 75 mg. Okay. So this figure taken from the mentioned CPG lah, risk stratification of unstable angina and non-ST elevation MI. So bear in mind that this both patient with high risk lah, patient with recurrent chest pain, early post-infarction, unstable angina, dynamic ST segment changes, elevated cardiac biomarker, and patient have diabetes, hemodynamically instability, left ventricular ejection fraction less than 40%, then ada major arrhythmia lah, VF or VT. So yang ni kita macam suspect kan kena buat angiography or revascularization lah. Okay, kalau patient datang dengan chest pain, kita kena buat continuous ECG monitoring, okay, GTN, okay, DAPT, analgesia, kita boleh bagi IV morphine dengan oksigen lah. So kalau patient presenting to us within 3 hours from the onset of the symptom, okay, primary PCI or fibrinolytic therapy is equivalent je. Tapi kalau patient tu ada contraindication to fibrinolytic ataupun patient ni high risk, kita we need to do primary PCI. Primary PCI is the preferred option. Kalau within 3 to 12 hours from the onset of the symptom, okay, primary PCI is the preferred one lah. Okay, kalau more than 12 hours from the onset of the chest pain, there's no tak ada guna dah primary PCI fibrinolytic therapy. Kita boleh only we can give medical therapy plus anti-thrombotic lah. Tapi kalau patient tu still ada ongoing ischemia, still complain of chest pain, okay, despite medical therapy more than 12 hours from the presenting symptom, okay, primary PCI may be considered lah in this patient. Okay. Okay. Reperfusion strategy, every patient with MI, ST elevation MI should have the occluded artery reopen lah. We call it as reperfusion therapy as soon as possible after the onset of the symptom. So reperfusion therapy is indicated in all patient with ischemia which is less than 12 hours from the onset of the system and they have persistent ST segment elevation lah. Okay, primary PCI is superior to fibrinolysis for ST elevation MI when performed in a timely manner at experienced centers. So the following factors are important consideration lah. Time from the symptom onset to first medical contact, time to PCI, time from hospital arrival to wire crossing lah, PCI. Okay, must take less than 2 hours. Okay, time to hospital, fibrinolysis, door to needle time. Does the patient have any contraindication to fibrinolytic therapy in high-risk patient? So high-risk patient, patient who have large infarcts, anterior infarct, patient who have hypotension and cardiogenic shock, or have significant arrhythmia in elderly patient, and patient who are post-revascularization, post-CABG or post-PCI and post-infarct angina. Okay, these are the contraindication for fibrinolytic therapy lah. Kalau patient ada contraindication ni, we need to straight away for PCI lah. Okay, absolute contraindication when patient have risk of any intracranial hemorrhage, such as history of intracranial bleed, history of ischemic stroke less than 3 months, non-cerebral vascular lesion, arterial venous malformation, and have no non-intracranial neoplasm. Okay, risk of bleeding such as active bleeding diastasis. Okay, we need to exclude menses lah. Significant head trauma less than 3 months, and suspected aortic dissection. Relative contraindication when patient have risk of intracranial hemorrhage, such as severe uncontrolled hypertension when BP more than 180/110, ischemic stroke more than 3 months, history of chronic or uncontrolled hypertension, risk of bleeding, use of anticoagulant, IR more than 2, recent major surgery less than 3 weeks, traumatic or prolonged CPR more than 10 minutes, recent internal bleeding less than 4 weeks, either from GI or urinary tract, non-compressible vascular puncture, active peptic ulcer, other related contraindication such as pregnancy. Okay, so fibrinolytic therapy, when given within 2 hours from the time of onset of symptom, we call it as the golden hour, is most beneficial and has been shown to be able to abort the infarction and reduce the mortality up to 50%. For a fibrinolytic agent as streptokinase or fibrin-specific agent lah. Kalau kita nak administer fibrinolytic therapy, the DNT, door to needle time, should be less than 30 minutes. Okay. So these are the differences between streptokinase and tenecteplase. Streptokinase is non-fibrin specific, is widely available. Okay, so streptokinase lower patency rate as compared to tenecteplase. So streptokinase produce dia ada antigenic punya effect, so it promote production of antibody. So kalau patient kita bagi streptokinase, so kalau kita bagi NETs, dia less effective lah kalau given between 3 days even 4 years after the first administration of the STK lah, sebab production of the antibodies tu. Kalau tenecteplase, dia not antigenic lah, so dia tak ada promote antibody, tapi dia disadvantages dia higher patency rate because more rapid reperfusion of the occluded artery. So STK kita boleh bagi 1.5 mega unit in 100 cc normal saline or in dextrose 5% lah over 1 hours. So tenecteplase is a weight-based bolus regime. Okay, kalau patient less than 60 kg, we can give up to 30 mg, 60 to 70 kg, 35 mg and so on. So these are some issues that we may encounter during fibrinolytic therapy, such as hypotension. So kalau BP dia hypotensive, we can run IV drip lah, ataupun can start on inotrope. Kalau boleh ada hemorrhage event juga, so might withhold the infusion and might transfuse the FPP or IV tranexamic acid lah. Allergic reaction, okay, we can withhold the infusion and give IV hydrocodone and piriton stat. Also, patient might have erythema during fibrinolytic therapy. So, what are successful reperfusion? If the chest pain is if patient have no more complaint of chest pain, early return of ST elevation to isoelectric line or reduce the height of ST elevation by 50%, early peak CK and CKMB, and patient restoration of hemodynamic instability lah. Okay. Kalau kita administer fibrin specific agent, so kita kena bagi anticoagulant, either heparin or enoxaparin, okay, within at least 48 hours. Okay, what are the failed reperfusion? Failed reperfusion is when failure of the fibrinolytic agent to open the occluded artery. So, maksudnya patient tu masih, bila kita dah bagi STK semua, patient masih complain ada chest pain. So, kalau buat ECG pun masih ada ST segment elevation tu. Okay, so dengan hemodynamic instability lagi lah. So, maksudnya kalau patient fail STK semua tu, kita kena treatment of choice yang ada PCI lah, rescue PCI. Okay. They should not be given a second dose of fibrinolytic agent. So these are the different type of PCI. Primary PCI is preferred if less than 12 hours. PCI post fibrinolysis, if patient fail lah, macam tadi fail fibrinolytic, so we need to rescue PCI. Facilitated PCI. Okay, when patient plan for immediate PCI after reduced dose of fibrinolytic agent. Okay. Routine angiography, okay, delay angiography, PCI symptom, okay, onset more than 12 hours, and delay selective angiography. Okay. So this figure show time interval to determine the choice of reperfusion strategy. So when the onset of the chest pain, dia nak cakap kalau onset of chest pain tu dengan time to wire crossing ni, wire crossing ni maksudnya PCI lah, kena patient sampai hospital kena PCI center tu kena less than 2 hours, 120 minutes. Okay. Kalau kita expect patient nak sampai PCI center tu more than 2 hours, then we need to initiate fibrinolysis first, and then baru transfer patient to PCI center. What are the complications of ST elevation MI? Arrhythmia, left ventricular dysfunction and shock, mechanical complications, right ventricular infarction. Others include pericarditis, left ventricular dysfunction and cardiogenic shock. Okay. So these are the prognosis post fibrinolysis and post primary PCI lah, according to the clinic classification. Kalau patient ada clinic class 1, dia punya 21 day mortality tu low lah, 7%. Okay, the higher the class, the higher the mortality rate lah. Kalau class 4, dia punya 21 day mortality lagi high, 70%. Okay, so last slide for management of MI is bear in mind that there's ST elevation MI equivalent lah. Maksudnya kat dalam yang ni semua boleh ada ST elevation, dia mimik juga. What are there? Williams syndrome, okay, AVR ST elevation with diffuse ST depression, left bundle branch block, okay, D winter pattern, out of hospital cardiac arrest, subtle inferior or lateral MI, hyperacute T wave, and isolated posterior. And there's ST depression more than 2 mm in V1 to V3 with ST elevation in posterior lip. Okay, I think that's all for management of MI in ED. Any question?
Any question from the floor? Sorry internet saya putus-putus. Okay, my comment, AQMI ni is a very long punya presentation. It require 2 times lah. First part is recognition of the AQMI itself, and plus ECG recognition. And the second part is management. So macam tak fair juga lah untuk you untuk present the whole in one presentation. Okay, the most important part of AQMI, early diagnosis of the AQMI itself. So, and also please remember, before you start reperfusion therapy, you must ask the patient regarding the absolute or as relative contraindication. If you tak tanya patient, then subsequent complication tu akan worse lah. For example, if you QMI ni dia akan datang dengan patient akan datang with multiple comorbid, then suddenly you miss dia ada recent stroke, then datang AQMI, then you bagi hepatitis ke atau metalize ke, then patient develop ICB. Additional tu complication of the fibrinolytic itu you bukan nak tahu juga, tapi itu you kena pada reading lah. Okay, the next the dose. Hello. The dose of the fibrinolytic tu, make sure you tahu option lah, STK or metalase ni.
Metalase.
Okay, if one question, tu ada disadvantage tu. STK ni dia adalah antigenic, so means dia once dia enter body, dia ada prone to risk of allergic reaction or anaphylactic. So yang tu pun kena tahu juga you how to handle it. How to handle it, Fadlina?
Apa kata?
If patient allergic STK.
Oh, allergic. Yang ni tadi. Withhold the infusion. Kita bagi IV hydrocot dengan piriton.
How you nak continue tak STK tu? You dah start 5 minit dah. Kan you nak off terus?
Continue. Lepas at the same time kita treat dia punya allergic tu, kita bagi IV hydrocot dengan piriton.
Okay. Whatever complication of the STK, for example, patient develop anaphylactic, you kena treat anaphylactic first, and then hold first the STK. Then once stable, you continue. But a bit slower rate. Then continuous monitoring lah. Okay?
Okay.
Anything? Anyone have a question regarding the AKMI management? If tak ada, kita proceed second presentation. Second presentation pun a bit topik lah. Require multiple presentation. Proceed.
Thank you, NAZRUL.
Thank you.